want to welcome Dr. Jasleen Chhatwal. Dr. Jasleen Chatwal is the president of the the Arizona Psychiatric Society, representing over 500 psychiatrists in Arizona. A board-certified psychiatrist, Dr. Chatwal also serves as the chief medical officer at Sierra Tucson and as assistant professor at the University of Arizona College of Medicine. She is trained in psychodynamic, psychotherapy, cognitive behavioral therapy, psychopharmacological, neuromodulation, including ECT and rTMS, and various emerging modalities. She further completed fellowship training in the Integrative Medicine from the renowned Andrew Weil Center for Integrative Medicine. So Jasleen, thank you so much for joining us today. And I'm gonna turn off my video and you're welcome to start your presentation, but welcome to OLLI and thank you so much for your time today.
Thank you, Scott, and thank you everybody for joining us today. I know that we all have a lot of Zoom time in this past year, so anybody who's willing to jump on Zoom and connect with me, I'm ever grateful, and I appreciate you being here and being willing to hear about the state of mental health in Arizona. I'll be going ahead and sharing my screen to start my presentation. Here we go. As always, it just takes one extra second than you're expecting it to. So today we'll be talking about the state of mental health in Arizona. And I chose the title of this very curious book by Lewis Carroll because I do feel that mental health is really one of those things. It's curious, it's confusing, and it's been made more complicated than it ever needed to be. But here we are looking at it from the future, the past, and also continuing to be befuddled and puzzled by what it is that we are in the middle of. And I think now, especially due to the pandemic, I thought this was a good time for us to be talking about this because mental health has been getting more attention. And in my book, this is one of the positive things that maybe we can see come out of such suffering during this pandemic, that we are starting to recognize that mental health is a very important component of health and something that we definitely need to pay attention to and make sure that we're addressing more actively rather than waiting till it gets really bad in our state as well as for ourselves personally. So I think like Scott introduced me, I wear many hats as a lot of us do during our working lives. Currently, I speak to you as president of the Arizona Psychiatric Society, but personally, I really speak to you as a human being who knows many others who have mental health illnesses. I myself am a suicide survivor. I had lost my father to suicide many years ago, and that's really where my own interest in mental health while being a physician got really piqued as I started to notice the amount of stigma, the amount of secrets that would really get brought up whenever the topic of mental health came up. I'm originally from India, so I finished my medical school there, and then I moved to Arizona, which is my second home, and now really my first home, and I've been here for the past 10 years working in mental health. And so even just looking at these past 10 years that I've been active and looking further back at the history, it's always enlightening to see how much the past can tell us about what will work in the future and how when we all come together, things can get a whole lot better. Starting with our presentation today, first of all, what is mental health? And I'm starting with this definition because I do feel, again, that mental health is something that's confused very much and made more complex. So mental health truly is a state of well-being in which every individual can realize his or her own potential so that they can cope with the normal stresses of life, work productively and fruitfully, and be able to make a contribution to your community. These are not very complex things. These are not very high bars. And all of us had mental health. Whether we have a mental illness that we've ever struggled with, we've usually had some or the other struggle in the general realm of mental health. And that is why I think each of us should be curious and aware of what is going on in the mental health community. So looking at Mental Health America's State of Mental Health survey back in 2015, it was interesting to me that our state of Arizona, right there in the Southwest, was ranked 51. So 51 out of 51 states, we were right rock bottom. We were not doing very well in each of the areas that Mental Health America usually looks at, which is access to care, also the amount of mental illness or individuals suffering from mental illness and mental health conditions were in the state, and then also looking at the ways insurance and other government carriers will cover mental health, how much legislation is positive and supportive of mental health services. And so we were rock bottom. And this is around the time that I myself was graduating from residency. So I remember during my training years, we would always talk about, our state is rock bottom. So when we would usually have struggles in providing our patients with the requisite care that we thought they needed, we would usually just bemoan the fact that we were in a state which was right at the bottom of the type of mental health services that were provided. And it was disheartening. I think it was also one of those things that always made me question, what is it that we could do? How is it that I, as a single physician, as one person, could start to make a difference? And this is where I would say my own interest in looking at the overall picture of mental health started to become more, I guess, obvious. And then I started to get more engaged in understanding how mental health was provided across our state. During our residency training, we are taught a little bit about it. We understand who the main players are. But again, since we're very busy learning about how to give good care to individuals, we're not often looking at the whole healthcare system. So this is essentially a time when, again, in 2018, we were second worst for addressing mental health issues. And then as of last year, we started to notice that our mental health care providers, the total numbers that we have are very low, which we've known for a while. And that started to become a really important issue that came into focus. We've had our governor chime in about it, and our governor especially chimed in about youth suicides and youth mental health that has been worsening in our state for many years. The good thing about all of this attention is that we can look at these factors individually that impact the state of mental health, and then we can start to parse them out into individual little bits and start to say, okay, what can I do about it? Where do I really make a difference? So the first thing that factors into these rankings is the prevalence of mental illness. So that can be severe mental illness. Usually SMI, or severe mental illness, is considered to be a type of mental health issue that keeps you from functioning fully in your life, that impairs your ability and can often lead to disability. Any mental illness is more of a broad term for mental health issues. These can be conditions that don't functionally impair us and make us disabled, but still affect our ability to live our lives fully. So these can be depression, anxiety, even substance use to some degree, postpartum depression, etc. And usually the difference between any mental illness and severe mental illness is not always just the diagnoses. It can also be just the overall severity and functional impairment that the condition causes you. Another issue that's very prevalent and impacts our ranking in the state is access to care. So that includes availability of appropriate services. So if you know somebody who is currently very depressed, cannot function on their own, are they able to get inpatient services? Are they able to get residential services where they can go to a place for 3 to 4 weeks or even longer and be able to gradually recuperate? Are they able to access an outpatient doctor when they want to stay home with their family, get the support, and just go see a physician or a therapist and come back? Another thing that impacts access to care is just the mental health workforce. Do we have enough physicians, enough psychiatrists who can treat mental health conditions? Do we have enough nurses who can provide psychiatric nursing support? Do we have enough therapists? Again, so it's a bigger issue, and access to care is a very, very complex thing. I don't want to make it sound very simple, but again, it does for an individual. When I'm looking for mental health services, it really boils down to, can I get what I need? And then finally, there's also mental health parity. This is a little bit more of a technical term, and those of us in mental health and even medicine sometimes struggle with it. But what mental health parity stands for is essentially, do mental health conditions get treated on an equal platform to physical health conditions? So say if you were to go to a hospital to go get treated for GI issues or liver issues, the amount of services that you get, the difficulty you have in finding a doctor, et cetera, should be on par with mental health. But we know that that's not true for any of us who work in mental health, and for others who try to access it. It can often take months to get into seeing a mental health provider. And we also notice that a lot of people don't have doctors who are in network with their insurances, that is, they're sort of approved with and have the little stamp of approval of insurance. And so often people have to go outside of network, which typically means higher copays, higher costs, and higher paperwork burdens. Another thing can be just general barriers to accessing care. This can be because we live very far away from a major metropolis where there is higher level of psychiatric care. So working here in Tucson and having trained in Tucson, we would notice people coming from far off, maybe 2 or 3 hours. Sometimes they would have to travel to come and get care. And we would also sometimes notice that people had to be flown into Tucson for emergent care. And then finally, there is stigma and lack of knowledge around mental health. So an inability to fully understand that mental health is just health. You know, if I can get high blood pressure, if I can have diabetes and talk about it openly, then why can't I do that for mental health? But we know, again, from our experiences, that usually that is not something that's treated on an equal footing. So we'll talk about each of these 4 pieces a little bit more in depth. So looking here at prevalence of mental illness. This is a map of the US, as you all recognize, and it talks about how many adults have mental illness in the US. So a survey from 2017 to 2018, the data collected showed that in the US itself, we averaged about 19% of adults who had mental health issues. So that's about 1 in 5 people. As we started to look at the individual states, you notice that the numbers are a little bit different. And some of you may not be from Arizona, so feel free to look at your state. There are the percentages at the bottom right here. But when it came to Arizona, Arizona actually is very close to the US average. Our average was 19.2%. So that's where we're just about as many people on average with mental illness in our state as there are in any other place in the US. And when we look at the number of adults who have been reporting anxiety or depressive disorders during the COVID-19 pandemic, we see a very different number. So we see that that number from 2017 to 2018 has increased to almost 40%, both for the US and also for Arizona. And this is where the survey was done by, or the data was collected by the Kaiser Family Foundation. And there is a little bit more information at the bottom of the slide. These were done through survey data, which was a little bit random, so it's not as comprehensive as data that may be collected by the CDC or SAMHSA. But again, this is something that's reflective of how much we were noticing in the news, people talking about depressive conditions, anxiety disorders, and other things peaking during the pandemic. In the same survey, they also looked at adults who had a private insurance who were reporting a diagnosed mental illness back in 2017, 2018. And the number is about 17.5%, similar again to the US average. And then also they looked at adults with Medicaid who reported any mental illness in that 2017 to 2018 window. The reason I'm talking about 2017 to 2018 is because it takes a little bit to collect the data and put it together. So we're usually lagging behind a few years. And I had shared that one slide from last year because I thought it was very pertinent to speaking about how last year impacted mental health care need, as well as the questions being raised about mental health access. And as you notice from this last slide, so between private insurance and Medicaid, which in our state is called access, we do notice that there's a significant bump in the number of people with mental health conditions who are on Medicaid. And this may speak a little bit to that SMI, severe mental illness population we were talking. And for those of you who are interested a little bit more in socio-cultural effects as well as socio-demographic effects on mental health, these are also really indicative of what we call interrelated, as well as increasing levels of mental health determinants that are impacted because of poverty, because of homelessness, and because of lack of stable environment in homes where parents may have to work multiple jobs. So we start to notice that some of those factors that may play into mental health are really socio-demographic or socioeconomic factors. And then we look at individuals in Arizona who are reporting a major depressive episode in the past year by age group in 2017, 2018. This slide is really more so to speak to that difference between adults and young people. We are noticing that our youth nowadays is bereft with more mental health issues than ever before, and that the rates of mental health issues have been increasing year by year. So we noticed that adults were reporting about 7.2% of major depressive episodes, which is a clinical episode of depression. And then adolescents were reporting it about double the rate, or slightly more than double. And when we look at an age-adjusted suicide rate per 100,000 people, we also notice here that we start to see a difference between the United States data and the Arizona data. This is one place where there is a lot of concern in the mental health community, as well as in mental health advocates. And we'll be talking a little bit later about what we've been doing as a result. But this is a very concerning number that we have 19 suicides per 100,000 in our state. And looking further at this suicide data per ages, we notice that suicide is the leading cause of death in ages from 1 to 14, it comes in at number 3. And that's very sad because these are children who have not even reached adulthood, not even fully seen their teenage years, and they're already so impacted by mental health conditions that they are dying by suicide. We also notice between the ages of 15 to 44 that suicide becomes the second largest number or cause for deaths. So again, between that age of the young people who are barely reaching adulthood and then young adults into middle age. And then we notice further that as we go beyond the age of 45, that other conditions which are considered chronic health conditions also similar to mental health start to take over as those causes of death. Looking at this data in a slightly different way, when you look at cause of death overall, suicide is number 7. But when you look at suicide through the lens of years of potential life lost, then suicide climbs to number 4. And the reason this is very important is because our young people are getting impacted so much more by it, that we're losing more years of productive life and hence also spending a lot more money. One of the other pieces of data that sometimes I like to share is that because of mental health conditions, we lose more years of life than we lose because of all cancers and heart disease combined. So that's really a very concerning number, because not only do we lose productive years, but we also spend a lot of money in rehabilitating, supporting individuals with mental illness when we catch them too late and are not able to rehabilitate them to the point that they can live a functional life. Looking further at this data slightly differently, I'm not going to stay on this very long. So the data on the left-hand side is that suicide data from a slightly different time frame between 2013 and 2017. The number is slightly lower than the prior data set that we looked at. But also then when you look to the right about causes of suicide or reasons or means through which people complete suicide, we start to notice that firearms are one of the highest number. And we are, again, a state that has very easy firearm access for people. We are able to reduce firearm access for people who've been on involuntary treatment or involuntary mental health treatment, but that may be way too far down the line, because usually it's at the place where people are very functional and you're being able to live a very full life, and you start to notice that, oh, guess what, I'm not where I used to be before and things are declining for me. It's really in that gray zone that we notice that a lot more people successfully attempt and complete suicide, which is a tragedy at this point in our state. And breaking this information by gender and age, the dark blue represents men and the kind of teal green blue represents females. So you notice that males are usually more prone to complete suicide and die by suicide. So when I, as a psychiatrist, I'm seeing an individual in my clinic or in my practice, I'll usually notice male gender as a risk factor. And it's not because men have suicidal thoughts more than women. It's just often we notice that men use more lethal means than women do. And that's where they don't actually get the opportunity to get the help that somebody may get after an attempt. So again, if you know anybody who is alone or lives alone, doesn't have a lot of support, it may be worthwhile checking in with them, making sure that they know that you're there as a source of support, and to connect them with services in the community or encourage them to go get help if they need. Because this data is very concerning and causes a lot of us to pause and realize that we're losing a lot of people just because we're not being able to react in a timely way and intervene early enough. We're going to look at some youth data from that time frame. Back in 2017, about a third of youth mentioned that they felt sad or hopeless. And this is at a time that they're just starting with their lives. And then also looking at high school students through the same data set, about 11 to 12% of them reported having a suicide attempt, whereas in the US, that number is closer to 7.5. And then also looking at substance use, which is use of something that alters your mental state. It can be alcohol, marijuana, opiates, methamphetamines, other types of things, like sometimes kids will get their hands on stimulants. And as you look at those, the three big ones that are marked here are alcohol, marijuana, and prescription pain relievers. And we start to notice that our youth are using in 8th grade and even more in 10th grade, and then further in 12th grade when it comes to alcohol and marijuana, whereas it seems like prescription pain relievers very gradually start to reduce. And now looking at adults who have, adults and adolescents who have used alcohol in the past year to the point of having alcohol dependence or alcohol abuse diagnoses, we noticed that adolescents already have a diagnosis up to about 2% and adults about 6%. So our young people are getting started very early in some places. And then similarly, when we look at illicit drug use, so these are all illegal drugs, which till very recently also included marijuana. In our very recent election, it seems like we may have passed to make marijuana legal in the US, which will happen in the next year or so. So I would be intrigued, and I'm a little disheartened by that change, but I'd be intrigued to see how these numbers change as a result. And then we look at rates of opioid overdose, so still looking at just rates of mental illness in our state. As we start looking at rates of opioid overdose, we also notice that Arizona is now crossing the US, where previously the US and Arizona were both going up together. Now it seems like in the other parts of the US, we've started a trend down, but in Arizona, we've continued to trend up, and we're at about 1.5% higher than the US at this point. Looking further, we notice that people who have a history of substance use are typically most likely to have opioid overdoses. So you can have a history of alcohol, marijuana, illicit drugs. Also, if you have chronic pain, that can be a risk factor. But as you start looking at some of those risk factors, anxiety, depression, suicidal ideation, bipolar disorder, the top 6 conditions out of those 5 are mental health conditions. So we understand that a lot of these co-occur when you have one mental health condition. Sometimes moving towards substance abuse or substance use disorder can become a lot easier. And some data on binge drinking in the US and Arizona. And then also I attached a map which shows how we're arranged per counties. And we noticed that some of our counties have slightly higher rates than others, Maricopa, Yuma, Coconino being the ones that are most prevalent. The next piece I'd like to touch upon is access to care. And I guess I may want to tell you that I'm hoping the news gets a little bit better as we start trending through this presentation. I don't want it to be just purely depressing, which is what it seems a little bit right now. Looking at access to care. Access to care, like I said earlier, is a very broad topic. It usually refers to not only are you able to kind of get the care you need, but also is it the appropriate type of care? Are you getting it in a timely way? Is it costing you the amount it should, rather than becoming financially burdensome to where a lot of people may not be able to access it? So we noticed that in the past year, in that 2017 to 2018 data, they looked at adults who had mental health issues who did not receive mental health treatment, and were at 50% or more across the board. And it seems like when it's mild or moderate, people are less likely to actually get caught by the mental health treatment system. And maybe in the cases of serious mental illness, there are a little bit more safety nets and the Medicaid packages that can support people in getting treatment. Again, as you notice, there are some areas in which Arizona does a little bit better, which in this case is mild to moderate mental illness, whereas in terms of serious mental illness, there are still a lot of people who are getting missed. Looking again at people who are adults who had anxiety or depressive disorder and did not get access to counseling or therapy. This is from 2020, so just these past 6 months or so ago. We noticed that Arizona is almost in line with the US, where there's 20 to 24% of people who are not being able to get treatment in terms of therapy and counseling. Out-of-pocket spending. So this is where we were talking about, the financial burden of it. So as you notice, people without mental illness have a much lesser financial burden than those with mental illness, both in the US as well as in Arizona, which shows that there's something that's broken about our mental health system that makes it so it's more expensive to get help. And as I was mentioning the social determinants earlier, we know that it's harder for those people to afford it. So it's a double-edged afford right there. And then we have something in healthcare that we call mental health care, health professional shortage areas. It's a fancy term to say what are parts and where are areas that you don't have enough doctors. So in Arizona, we have a lot of healthcare professional shortage areas, especially when it comes to mental health. And out of our entire need, we've only met 11% of the need. So we still have a long ways to go. And in the US, in these areas, we've gone up to about 27%. So again, doing much better than we as a state are. And the number of people to remove that designation for Arizona alone would be 181 practitioners. One of the pieces that's very important to the mental health care puzzle is access, or the Arizona healthcare cost containment system. It has been Arizona's answer to providing health care to people who are not able to afford private insurance or may not be functional enough to be able to have a job and hence are disabled and using access. So access is provided to different groups of people. And under the umbrella of access, there are 3 different areas that get demarcated. One is North Arizona, Central Arizona, which essentially is Maricopa County, and then South Arizona. Each of these areas are served by a regional behavioral health association, and these REBAs have to submit a new bid, and new REBAs can come and take the place of the current one about every 4 years, to where they can show that they may be able to do better than the last person was doing and hence be able to get that contract. So in the Pima County area, we have Arizona Complete Health, and they are our REBA. So they essentially get money from the state that they funnel out to other people who are providing care. In Central, which is Maricopa, it's Mercy Care. And in Northern Arizona, it's Health Choice Arizona. As you notice, both in North Arizona and South Arizona, the geographical region is very wide, which means we have a lot of rural areas. And when we start to look at the number of psychiatrists or psychiatric practitioners who are really available to deliver care, the numbers in North Arizona as well as Southern Arizona can be very dismal. In Maricopa, we see that there's greater numbers of people who can provide services, but again, because of their population density, they too are falling short of the type of care that is required. Access has done some pretty neat things in recent years. They did expand Medicaid a few years ago, which has helped cover more people. Additionally, around 2014, they asked people who were providing mental health to also provide physical health, because we noticed that when somebody has a mental health condition, they also have much worse physical health. And often they are not very good about going to get physical health services. And so what Access has required is that a physical health provider be co-located in the same clinic where mental health services are being provided. Those services are continued to be expanded. So the hope is that as we progress along this path, that we'll have greater and greater integration between physical health and mental health. There are some other positive moves that have happened. So one is telemedicine. A lot of you may have seen your doctors through telemedicine this year. I had a really interesting experience where I actually saw my pulmonologist through telemedicine. And it was a little amusing for me because I didn't know how they could check my lungs while being on tele. Interestingly, for mental health, we are better served and are actually able to provide medical care pretty well through telehealth. There has been some data gathered by the governor's office that hasn't been released yet, but it shows that especially in the area of mental health, we're doing very well in being able to use telemedicine to provide services. And it may actually be the answer to people being very far away. We also know that not everybody is served by telemedicine, so there needs to be continuous innovation in looking at other things. But in terms of telemedicine, there was an amendment back in 2018, which asked insurance policies to cover all healthcare services that are covered in person, even through telemedicine. So that was an initial start. It had some caveats to it. Then back in 2020 March, our governor, Doug Ducey, he signed an executive order which made it that during the healthcare emergency of COVID, every insurance company had to provide the same service through telehealth that it did in person, obviously not surgery, but anything that could be provided that way and cover those from an insurance coverage perspective. And finally, the one legislation this year that I'm very excited about is a Telehealth Omnibus that is in process of going through our legislative council. So we'll be seeing what comes of it, and if there is any change. It has a lot of support on both sides of the aisle, so that is exciting for us here in Arizona. And then another legislation that passed in 2019 that also addresses access to care actually provided $50 million. Yes, you're not hearing or reading it wrong. $50 million to graduate medical education, which essentially stands for residency program development. So the type of place that I went to get trained as a psychiatrist, also University of Arizona Medical School, so that they can provide more education and expand medical school seats for people who will go into rural service later. Also, they've expanded some of the monies in the $50 million have been used to expand primary care loan repayments so that more people want to be primary care providers, go into family medicine and take care of us and do our preventative health. And then also to help with medical student loan repayment, because that is a huge burden on physicians, and that makes them typically take high-paying jobs versus going to areas which may be in greater need and may not be able to pay that well. And then finally, the last bit of money is going to be used for nurse training. So this is something that's a very positive move and will definitely be helpful in addressing one of the big issues, which is access to care. Okay, next piece, we'll talk about mental health parity. So again, we go back to our little state report card. So this was a different type of report card. It was evaluating state mental health and addiction parity statutes, which means it's looking at legislation that says how mental health is to be provided, what are criteria that need to be used to provide us services. And we noticed that Arizona got 26 out of 100 points, and we failed. This data was collected by the Kennedy Center, and the Kennedy Forum and Kennedy Foundation usually has done a lot of work in the area of mental health parity. They've been huge supporters and usually also helped with legislative writing and helping with assessing different states and looking at what could be made better. If at all you're interested, you can Google search the Kennedy Forum and look up more interesting data that they pull up. So when we started looking at mental health parity, it really means treating mental and physical health the same. So how do we do? So here in Arizona, something called inpatient out-of-network utilization. So this is whether when you have to go for a mental health condition to the inpatient hospital where you have to go stay overnight, how do we do in comparison to when you need to go to the hospital and stay for a physical health condition? And as we noticed, both nationally as well as in Arizona, we don't do very well. From the perspective of just looking at the gap between national and Arizona, we definitely have that, but we also have to recognize that all across the country, this is not going very well. And we may need to dig a little bit deeper to see how historically we've gotten to this point. Similarly, when you look at outpatient facility out-of-network utilization, we again notice that both nationally and in Arizona, it's a lot worse. And when we crunch the data a little bit more, we noticed that in Arizona, the out-of-network use increased from 4.6 to almost 6.7 times. So there was a substantial increase just in between 2013 and 2017. So we're not headed in the right direction there, which may speak to more number of people trying to get mental health care, or may also speak to the fact that our networks are actually closing down and we're not being able to provide the same amount of care that we were before. Similarly, looking at outpatient, out-of-office, out-of-network utilization, we noticed that it's fairly high. We do see that nationally, it's actually worse than it is in Arizona. So that might be a little bit good news for the state. As you see, there's another new bar that has come up, which is that gray bar. The gray bar compares how much you have to go out of network, whether you're going to a specialist. So say you have, some sort of healthcare condition, you go to your primary care doctor and they send you, like they sent me, to a pulmonologist. So me being able to get a pulmonologist, I'll have an easier job than maybe me trying to get mental health care. And then finally, the last slide out of these is on provider reimbursement. So this is how do they pay the doctors who are doing this work? And what we notice is that all through the country, and also in Arizona, people who work in behavioral health get paid a lot less by insurance companies than your primary care doctor or your specialist gets paid. And when we look at the data per some codes that we build, we notice that it's an 11% reduction. So it may mean that something that somebody else would do for about $100, we both submit the same bill. One person will get $100 or might even get $110. And somebody like myself who's in mental health will get a lesser amount, maybe close to 89 or 90. And so we start noticing gradually that financial pull pulls people away from behavioral health and into other more lucrative specialties. And sometimes we also notice that makes it so a lot of psychiatrists may not work with insurance companies because they feel like they're not being treated well by them and not having to jump through a lot more hoops than a regular doctor. So what did we do about it? Now coming to some good news, finally. So last year on March 3rd, 2020, we passed something called Jake's Law. This was passed in Arizona by the Arizona both houses, as well as signed into law by Governor Doug Ducey. I was going to call him a doctor. Maybe someday he'll get a doctorate, but I don't think he's a doctor at this point. But Governor Doug Ducey was very supportive of this legislation. We had bipartisan support in both houses, and it was called Jake's Law because of a young boy who lost his life to suicide. His parents are actually pictured here in this photo. They are Ben and Denise Denslow, and they have dedicated their life after Jake's passing to making sure that no other family loses a child to suicide. So they've both been very, very active, and they have a foundation called GEM, J-E-M Foundation, that they've started, and they were part of the cohort that worked on Jake's Law. And they were some of the people who had the most traction with legislators because understandably they had lost so much that their voice was important for our legislators to hear and for them to really know that they didn't want somebody else to go through the same loss and pain that they've had to go through. So Jake's Law provides a lot of different things. It requires insurance companies that cover mental health treatment on an equal footing with physical health services. For those of us who work in mental health, we feel somewhat frustrated that we needed to do this all over again, because in 2008, there was a national law, a federal law that was passed that was called the Mental Health Parity and Addiction Equity Act that required that exact same thing. But given that we have such different laws and rules federally and then in our states, and that a lot of the insurance accountability actually comes from the state government, it was important to go through with this process so that our state would have the same standards that are really being set federally. This law actually went above and beyond just regular mental health parity, and also created a Children's Behavioral Health Services Fund, which had monies in it so that children who are from uninsured or underinsured families can get the behavioral health services that they need. It also prohibited insurance companies from denying coverage to people, especially children, simply because the care was being provided in the school. And this was really important because oftentimes we noticed that people who were from lower income families, the parent would have to leave their workplace, not get paid, pick up their kid from school, who now would miss many hours of education, to take them to a doctor's appointment. And so what the Children's Behavioral Health Services Fund has done is it's expanded the ability for schools and school systems to provide healthcare within schools. And on speaking with some of my colleagues who are in child psychiatry, I've been very pleased to hear that they are noticing trickle-down effects of this already, and they've already been able to see some of their young children patients who are being able to get the care that they need. And then also Jake's Law established a mental health parity advisory committee on which our last president of the Arizona Psychiatric Society, Dr. Don Fowles, is a member. And it also has members from people who are themselves family members of individuals with mental health conditions, providers similar to Dr. Fowles. Then there's also individuals from advocacy organizations, which we are as well, and then also representation from insurers. The role of this committee is to work with the Department of Insurance so that they can help them really devise good questions and good tools and excellent rules that will help us continue what this law really hopes to achieve. Because sometimes it is, you can have a really nice law, but if it doesn't get enforced, then it's really no good. So the Mental Health Parity Advisory Committee is really set to do that. And then it also creates a suicide mortality review team that is going to review deaths that occur by suicide and then gradually start to make recommendations on what we should be doing differently in our state. Because as we noticed in the first set of slides around mental illness in the state of Arizona, that our suicide rate is much higher than that of the national average. And then finally, Jake's Law, again, this is not exhaustive. These are just the points that I thought were most pertinent. It helps increase follow-up services for patients at risk of suicide. So if somebody were to go into a hospital because they're having suicidal thoughts, it makes it so that the facility, before discharging them, will need to have a very clear discharge plan addressing that suicidal ideation, and then also set them up with an appointment with a provider so that they're not left or lost to follow up. And so continuing this progress this year, 2021, I'm sometimes surprised that we're already here and into March. So our first and biggest task is doing the enforcement and rulemaking for Jake's Law. So that is where we are continuing to stay engaged with the Department of Insurance and also with the Parity Advisory Committee so that we can continue to provide input and have a voice and be able to make sure that people in Arizona are not left behind when it comes to mental health. And then federally, there was the American Rescue Plan Act that was passed, which increased funding for services. It also provided funding for wellness of healthcare workers, which has become an epidemic in and of itself. There are some other things that we as an organization are trying to do for healthcare providers, but it's kind of like fingers crossed, hopefully we get there and are able to make a positive change. The American Rescue Plan Act also increased Medicaid funding, especially for states that hadn't expanded Medicaid before, and especially also increased funding for children's mental health care grants so that people can do more innovative things and be able to provide children's services in a more timely manner so that we can reduce the years that are lost to mental health issues. Okay, taking a breather. Stigma and awareness about mental health. This is a topic that's very, very close to my heart. I had mentioned earlier that I am a suicide survivor and had lost my father to suicide. I share that very openly because I feel like many of us don't talk about this. And it is very important because oftentimes people don't seek help in a timely manner. And that's really where we lose our loved ones. And I always notice that even 13 years hence, whenever I talk about this, it brings up a lot of emotion. And that is something that happens even now when I have friends who call me up. So I have friends here in the US, across the world, in India. I have family members and friends who call me often asking me questions about mental health conditions. And I feel to some degree it's obviously because I'm a psychiatrist, but I also think it's because I do use my social media to talk about mental health. Whenever I am in a social setting, I don't hesitate to talk about mental health. So in some ways, my job, I feel, is to make it okay for people to talk about it. And that is one of the things that we do notice reduces stigma. And it also helps increase awareness. So all of you who are tuned in here today are, either already proponents of mental health or are now learning some things which will help you help other people in the future and just be more aware and on the watch for others who may be struggling. So stigma is a mark of disgrace. It is often a very negative attitude towards either a person or just whatever's going on with them that is considered tainted and discounts them. There's this beautiful definition by Irving Goffman from 1963 that I think bears true even now, that we usually look at a person who we are considering stigmatized as being somehow less than, like they're not quite the full person that somebody else may be. Stigma also is the single most important barrier that prevents people who are suffering from mental health from getting adequate care and treatment. They may feel like others may not consider them at the same level as they did before. They may not respect them. They may think they're crazy or different or odd. And it starts creating this vicious cycle of discrimination and social exclusion. So if we think somebody's different or, they're not like the other people we know, then we gradually start not really including them in our activities and treating them differently. And we notice that this has a lot of negative impact on individuals. And especially mental health stigma is important to talk about because as human beings, we just had a very complicated relationship with mental illness. Sometimes I do some lectures on cultural mental health and how in different cultures it's considered differently. And I've always been intrigued where some cultures consider you less of a person, others think you are possessed by the devil. And so there's just many of these historical facts that continue to complicate our relationship with mental illness. Types of stigma can be structural, social or public stigma, and then self-stigma. So structural stigma is really how our society is built up, how our healthcare system is built up. So again, that mental health parity issue that we were talking about really is something that can then add to structural stigma because you may feel, well, if it's so hard to access, maybe it's because, people are not really supposed to need this. Social or public stigma is just fear of how other people would feel about you. When I was sharing about how this is a personal topic for me, I know that my father did not share with anybody other than my mother and one or two close friends that he suffered from bipolar disorder. So I myself only learned 6 months before his passing that he had that condition. And his own biologic family, his parents, his siblings, just never knew about it because he was worried that they would somehow be additionally worried about him or that they would somehow think he wasn't the amazing son he was. And then self-stigma is internalized feelings by a person. And so this is me having depression, thinking, well, I'm not as strong as somebody else, or I'm somehow not good enough, or I may not be able to handle something because I have a mental health condition. This typically leads to us denying symptoms, rejecting treatment, continuing to say, I don't need it. I think I'll be okay. Oh, this is just a season, it'll pass. And then other times we also notice, and I hear that a lot from my patients, that they start to feel like other people may not understand. And so they start isolating and start to use things that may be maladaptive rather than really going and getting the help that would help move the needle forward. Some effective strategies for stigma reduction. So one of the biggest things is education. So again, I'm talking about it is spot on. Mental health literacy. This is getting more aware of what is depression, how can depression show up in people, what is anxiety, what is bipolar disorder. I often will stop people from saying, oh, so-and-so so bipolar. And we see that especially in youth, where there's this casual use of some of this mental health language, to really say that that's not a casual word to use, because typically it's used in a negative way, and that it is genuinely a condition that somebody may be going through. And when we casually use language, it may add to the stigma that person is feeling. Another thing is contact intervention. These are actual in-person or being able to see people who have lived mental illness and really see that they're no different from us. Peer services. So these are individuals who are in recovery, who have overcome acute mental health issues and are now doing well, who may then be able to show support and help others who are currently in an acute phase. And then finally, advocacy. And advocacy is something that we can all do at different levels. So education, mental health literacy, advocacy are things that each of us, even if we're not having a mental health issue, can actively pursue on our own. And we'll talk a little bit about each of these in detail. Education is trying to get factual information. It's usually for reducing public stigma, improving our attitudes, making it that in society it's less looked down upon. It also sometimes helps in reducing self-stigma, because we can understand, oh, it's just a health condition. It's not something that's a negative mark on me or somehow a weakness in myself. Another way of doing education is social media, where we may want to follow some reliable, notable sources so that we can get appropriate information. Sometimes education can have some negative consequences where it can highlight a differentness. So one can say, well, if I have a mental health condition, that means I have all these other risk factors. So that is one of the downfalls sometimes of education. And so obviously need to get this information in a supportive environment. Mental health literacy, it can be used in schools. It can also help others recognize illness or problems in individuals close to them. So one of the things that I used to feel very passionate about, and I think I still do, but I haven't quite gotten around to figuring out how to do that, is to provide education in schools about mental health. So I think that's where that Jake's Law and the additional monies and support for educating children is so important, because once the young people can see what depression, anxiety can look like, they may be able to recognize something in a peer and bring it to the attention of teachers or counselors. Mental health literacy also helps improve help seeking, and it may also show people how to respond in terms of a crisis. So there are some trainings which are provided by Mental Health Arizona or Mental Health America of Arizona or NAMI that can actually teach you that and help you be one of those people who can learn more about it. Then there's contact interventions. These, like I was saying, is really bringing people face to face with somebody who has a mental illness and realize how it's not very different. There are some public campaigns that can be done, which is having individuals who are willing to openly talk about mental health issues, share those, and doing articles or public awareness campaigns around it. It can also help improve self-stigma, where the person who, by the time they get to the point of being able to be open, they start to realize how they still get a lot of support from the kind of people they want support from. And usually we notice that doing education and contact-based interventions together has the biggest bang for our buck. And then peer services. This is, again, somebody who's in recovery, who is helping a person who is going through their process of recovery. And recovery is a verb, so it's always something that one is doing. We don't ever consider that a person is cured of mental health issues. We all have mental health issues, and somebody may have a diagnosed mental illness, but we all need to be in recovery along that longitudinal path. And finally, advocacy. So advocacy can focus on increasing rights, increasing access to resources. Typically, this is done by working with your legislator, working with journalists, also working with community officials. You can do this in the form of letter writing, which I think I maybe wrote my first letter like 2 or 3 years ago. And I've only started to get to know my legislators in the last couple of years. So it is not something that needs to be very complicated, which is what I used to feel it was. And I think because of coming from a different country, the legislative process in the US was just a complete mystery to me initially. And advocacy is really one of those things that is most effective in reducing structural barriers. So like we said, the recent legislation that I talked about, which can improve literal access to the number of doctors, to the type of services, to how you can get those services, to money to have grants to provide mental health services. So advocacy can be very powerful, and it can be done as part of an organization or individually. And it's a really useful stigma reduction technique. So here, coming to a little bit of a wrap, I want to read this little quote from Lewis Carroll which was spoken by Alice in the book Through the Looking Glass. It's a great, huge game of chess that's being played all over the world. If this is the world at all, you know. And mental health is that. It is a great game of chess. And it's being played world over. I do some work in India and also had the privilege of consulting in Africa last year. And we noticed that every single place in the world is struggling with mental health access and how to provide mental health services, because our prior ways of being in communities are a little bit broken off. And then previously people with mental health issues just didn't get the care. And we really do need to look at our world and see them with a new lens and start to discover how much there is that we can do and how much we can participate based on our capabilities, our available time, available energy, and really start to shape our world the way we want. So looking at the most recent Mental Health America survey from 2021, our overall ranking has still remained lower, but we're now at 40. So when we started this presentation, I had shared data from 2015, and in 2015, we were number 51. Now in 2021, with still some of the legislation that has been passed coming into effect, it'll take another 2 to 3 years, we're already up at 40, which shows that in these last 6 years, we've really put in effort as a state to improve our ability to provide treatment. We still continue to have challenges, but we're moving in a positive direction. Some of the other rankings, just for your reference, Mental Health America, they break them down through a few other things. So there's the adult ranking, there's adult prevalence of mental illness, youth ranking, children with insurance who did not get coverage for mental health services, overall access to care, adults with any mental illness who are uninsured, adults with any mental illness who did not receive treatment, adults with any mental illness who are reporting that they have unmet needs so that they are getting treatment, but it's not everything they need. And then finally, mental health workforce availability. There's more rankings, but these were the ones that I thought were pertinent to our discussion. And really looking at this, that we're doing okay in some areas. But when it comes to our youth, we're really not doing a great job. And when it comes to workforce availability, we're not doing a great job. The positive news is that just in the last year or two, we have passed legislation and are in the process of enforcing that is very directly supposed to focus on those areas. And so we will look in the next few years to see how we transition and how our rankings change. Some ongoing challenges in Arizona that we've discussed that are still present is enforcement of the mental health and substance use parity, mental health provider shortage, continuing the telemedicine access and insurance coverage, which is being done through that big omnibus this year, continuing to address increasing suicide rates in youth, providing equitable services between rural and urban counties, and then continuing to integrate both physical and mental health treatment, because there is no help without mental health, really. So what can you do? There were some strategies that we've discussed during the stigma part of the discussion. And so really the big takeaways are advocacy. You can do advocacy through professional organizations if you're a healthcare professional, or in any ways working within the mental health care or healthcare field. You can also do advocacy through organizations like Mental Health America, NAMI, which are available in almost every city and town. They have branches or offices that you can work with. There's also a NAMI walk that's coming up that can be sort of a small way of participating, just walking to increase awareness about mental health. And there's also the American Foundation of Suicide Prevention, which has local chapters. There's the Depression Bipolar Support Alliance. So there's a lot of different conditions based on which there are advocacy groups and then larger mental health advocacy groups that you can participate in. Another thing is engagement. One of my mentors at my training program used to say, if you're not at the table, you're on the menu. And I think that's where we as a society, as the Arizona Psychiatric Society, have decided we are not okay with mental health being on the menu. So we are trying to stay engaged and really continue to support the needs that our state has and engage with stakeholders. And then finally, tenacity. And the reason, I guess, tenacity is not really a thing you can do, but a thing that you have to keep in mind. Because these changes are not easy to make. These changes take time, but these changes will only happen if we continue to stay engaged and keep on coming back with our questions, our suggestions, our ideas. I had shared recently that sometimes when I'm giving presentations, I get a little bit of imposter syndrome, thinking like, why am I the one who's supposed to talk about this? What do I know more than somebody else? And there's always somebody who's more of an expert than I am. But I think the thing that I do have is tenacity. I am willing to come back and keep on asking the question. So I hope that some of you will too. And we'll end here. I know that I'm a little bit over the 60-minute mark, and we have about 20-ish minutes for questions. But I will end on this slide, which talks about what is life but a dream. And I like this saying because I'm a very optimistic person. I hope that someday we will have mental health be as ubiquitous in the world as gyms. So where we go to gyms for physical health treatment, that we will one day, all of us engage in things that help us continue to be engaged with mental health and provide mental health services in a regular way. And then finally, I'll pause at that and then see if we'll get some questions. And I think I saw some things pop up in the chat. Oh, there's Scott.
Yes,
friend.
thank you so much,
Hi.
Dr. Chhatwal, for your presentation. And we'll have a few questions, and just again, invite everybody to put questions into the chat and we'll help bring them on. And our first question comes from Brenda Neufeld. Brenda, if you'd like to unmute yourself, you can ask your question.
Yes, I wonder if you could just mention crisis services, especially county mobile and otherwise, that tying in with the police reform discussion that society's having at present.
Yeah. Thank you so much for bringing that up. Yes, we are having a discussion around police reform along with the American Psychological Association up in Phoenix. We've noticed that crisis services are very different across the state. In Pima County and also in Maricopa County, we do have crisis centers that are available that can be one of the biggest sources of crisis services, where they can provide not only education about conditions through their mental health counselors, but then also be able to provide resources about where to connect in your community for mental health services. So that is a good resource. We have something we call the MAC team down here in Pima County, and there's a similar team up in Maricopa County as well, which usually come up. So these are mental health counselors who are mobile crisis counselors who will go where the person is. So I've sometimes used this for my patients, where I will call the mobile crisis team and let them know that the individual is at so-and-so address and needs support, because I'm, not allowed to provide services at the home myself. And so those crisis services can be very helpful. What we've noticed is that in the state of Arizona, it started with having police officers who are trained in mental health. So these are called mental health support teams that we have in different cities. And the mental health support teams are really helpful if one were to call 911 and make sure to let the person who's responding to the call know that we're calling about a mental health emergency, so that they can specifically send their police officers who are trained in mental health. That makes it so that they're better at de-escalation if they need to talk somebody down from a crisis. They're also better at being able to engage the person and know that they need to go to a hospital and not go within the criminal justice system, which can be where a lot of people otherwise end up. And if you search for Crisis Response Network down here in Tucson, that is one of the places that provides the crisis services here. And then there's CRN Crisis Center up in Maricopa that can also provide services there. Thank you for that question, Brenda.
Our next question comes from Susan Rubin. Susan, if you'd like to unmute yourself.
Hi, Brenda. I was interested, Jasleen, I was interested in your comments on the stigma issue related to mental health. And it's kind of been my opinion that we kind of put that also on ourselves. So like, for example, with the legal community, you can get a guardianship for a person who has dementia, or if they have a medical condition that they can't make decisions for themselves. But if they have a mental health problem, you have to get a special guardianship. It can't just be just a guardian. It has to be a guardian with mental health powers. So somehow that's different. And also in our profession, like I know in my profession in social work, usually with a doctor-patient relationship, if the doctor treats you for a heart condition and you're better and you don't see him again because he cured you, and then you meet him in a social situation and you like him, you date, you go out together, nobody says a word about that. But if you're a therapist, or if you're a psychiatrist, or if you're a psychologist, or if you're dealing with a mental health issue and someone sees you and they're better and then they go off on their own and you see them again in a social situation, you're not allowed to have a relationship with them because mental health is somehow different. And so I think we have to look at ourselves as well before we also advocate for the rest of the community.
Yeah, thank you for bringing up that point, Susan. That's really well made. And I think, within our own professions, there's the ways that you highlighted where, like if my friend who's a family medicine doc, she can be my doctor and we're just fine, but I can't be her psychiatrist because then I can't really be, friends with her in that same way. That those are some burdens we put upon ourselves. Some of the reasons that I think that relationship piece comes up is that there has been a thought that when people share about mental health issues, especially in a therapeutic setting, when you're their therapist, that they are sharing really vulnerable parts of themselves. And so there had historically been concern that the person may take advantage and that there's sort of a power dynamic. But I think that's obviously worth looking at, and especially worth looking at where even within our own professions, oftentimes our licensing boards ask us questions that are stigmatizing of mental health, where we say, oh, well, you know, like if you had a mental health condition, you need to report it sometimes more than you're reporting other conditions. So these are worthwhile things to look at. I know that as an organization, or some of the mental health organizations were including the American Psychiatric Association, of which we are a little part, we were looking at reducing the HIPAA standards for mental health, where even when it comes to the health insurance patient protection act, that it's usually required that for mental health, you need to check a special box rather than just being able to cover your normal release of information with that. So that at least is a step that I know is being taken, but I would definitely look into, and if you share your email address or something with me, I'd be happy to respond back to you, but I'm going to try to look into seeing if there's any places that have tried to address the stigma that we place on people not being able to have more normal interactions. With myself, I usually have to tell my patients if they see me outside and they want to initiate a conversation, I'm happy for it, but that I'm not allowed to, and I think most of us do that.
I'm going to jump in with a question, I guess, about sort of data over time, and how is the country doing compared to, say, 10, 20, 30 years ago? Do we have data that kind of shows a trend line?
I guess it would depend on in which area. We are noticing that overall mental health conditions are on the rise. So the number of overall mental health diagnoses. So sometimes, you know, we look at it as a Western problem that both in Europe and then in the US, we're noticing in Canada that numbers are escalating. And we notice that in other parts of the world, which are called low and middle income countries, they're also escalating, but just not at the same rate. And sometimes, I guess there's data is sort of interesting because you can parse it different ways. But the question really becomes, is it that people are more willing to speak up now and that's why we're seeing the rise? Or is it truly that people are getting more sick now because of the amount of stress, the pace of life, and other things that are at play? But the simple answer is that we notice that mental health conditions are on the rise.
And you kind of alluded to that. How about root causes of sort of mental health issues? What kind of research is being done in that area?
Yeah, so that is an area that is being looked at. What we've noticed usually is that stress is one of the things, and stress is a very big term. The pieces that are most notable is isolation. So in the US, I think Vivek Murthy, who was one of our Surgeon Generals, had noted about a decade ago that isolation was becoming one of the most epidemic conditions in the US, where we were more isolated than ever before. There are more people living alone without even another person in the household than there have been in any time in history. So losing that sense of community may be one of the factors that's at play. There's also some suggestion that, you know, some drug use and then the increased amount of pace of life where we're required to do a lot more, we're comparing with each other a lot more on a broader scale, that those are some other factors that play in.
Thank you for that. J.L. Frank, if you'd like to unmute yourself and if you have a question.
Yes. I recently found out some diagnoses of physical ailments have now been attributed to anxiety. Nobody that knows me would ever think of me as an anxious person, nor had I. I thought I handled the stresses of the last 5 years politically without internalizing any of it. Obviously, I didn't. How does one recognize when we are internalizing stress to create anxiety? or
That is
result
a
of
really
anxiety?
good question. Yeah. And I would say, you know, again, without having actually met with you and done an assessment, it would be hard to generally to say specifically for you.
I
But
understand.
as a concept, what we notice is that sometimes emotional awareness can be sort of a spectrum, and some people can be raised in families where emotion is talked about a lot. So we're very much in touch with how we're feeling, and we have words for that. And then there are other times we grew up in families where, or in environments, you know, sometimes it's not even our family, it's just the type of temperament and such that we grew up in a way where we learn that I'm going to, you know, push through this, I'm going to muscle through this, I'm strong enough. And what starts to happen over time is that we can lose touch with how it feels in the body or that mental state. And so it may be that we're not having quite that same connection between what we're feeling and being able to name it. And so that's where other people who may be a little bit more aware of it may name it those things. So somebody else may notice certain things in you and then say, oh, this is anxiety. And what ends up happening is that we talk about anxiety like it's a separate thing. We talk about depression like it's a separate thing. But a lot of the research is showing that these are conditions that have increased inflammation in the body. And so when you have an increased stress level, which may cause anxiety, that anxiety, however else it manifests itself in terms of physical symptoms, it does cause your inflammation levels in your body to go up. So your brain and body respond as if they're being attacked by something, whereas the thing that they're being attacked by is this invisible stress. And so as inflammatory markers may increase in the body, we do start noticing that truly symptoms that are experienced physically can happen. And so it may be that even though somebody could tell a person, oh, this is because of mental stress and this is because of anxiety, that doesn't mean that that person is not having true physical symptoms and physical condition that may be occurring for them.
How often would the feeling of helplessness, like over the past 5 years under the previous administration, that helplessness, almost to a point of hopelessness, affect the anxiety?
Helplessness, I typically consider helplessness I would say some types of helplessness is really anxiety. There's other types of helplessness that may be more depression, where we feel like, oh, I can't do anything. But by the time we get to that kind of frozen state or broken down state, before that, we would have climbed up this whole curve of feeling pretty calm and then gradually feeling kind of irked and more worked up to the point where we want to do something, we want to go for a march, we want to do something else. And then we start getting sort of burnt out because it's continued for so long that energy we may have mustered to sort of fight that or like work against it or try to change the situation or change our mood or distract ourselves, we kind of get really tired, and that's when it can go to the point of helplessness. So it may be that the person's already gone over the curve of being really activated before they end up in that helpless place.
Okay, thank you.
Yeah, thank you for the question.
We've had a couple people, I'm very heartened to hear about Jake's Law and the changes taking place in the state with that, and have some background and experience with adolescent care in Tucson. And I'm kind of curious about resources and if they've improved over the last few years or not, because I know there've been, you mentioned all the sort of challenges anybody has in dealing with mental health. And then when you get into youth services, it gets even more complex, it seems, with harder to find providers that will work with the youth. When you do get into inpatient scenarios, the lack of beds and people having to be shipped off to Phoenix and other places. How has that changed in the last few years, or what kind of things are happening in that regard?
So again, I'm not a child psychiatrist, so I don't want to say that this is firsthand information. But from hearing from my colleagues, they are noticing that people are being able to get more funding when it comes to providing additional services. We have a few providers here in town and also in Phoenix who provide services for children. And we are noticing that they have greater capacity to treat children in different settings. They're also being able to send their staff to schools to provide counseling within the school system so that the child doesn't have to leave school. NAMI, I guess NAMI as well as Mental Health America, but NAMI more so has resources where they also work with schools and do school education. We have some national foundations that are also trying to do education in different school settings to provide education to children so that they can recognize things themselves, and then also to place counselors within the school system. So those are some of the positive changes that are occurring in the children's mental health space. And I think finally, with some of the new laws, there will be greater requirement for physicians or other practitioners when they're discharging children from inpatient units to make sure that they communicate directly with the family. In my mind, that's just something that's not acceptable if a family member does not fully understand what's going on for their loved one. And so I think those are some of the directions that we're going in.
We have somebody commenting about the NAMI program, ending the silence that I guess is taking place in schools as an example.
Yeah, that is one of the really fabulous programs. And I think we have some programs nationally that are being started that may be also able to provide education more exclusively in Spanish for school districts where Spanish-speaking children are predominant or children who are more comfortable with Spanish.
And how about the issue of beds in Tucson for people that have inpatient needs? Has that improved, or are we still having to send people north when we run out of room and things like that?
So I currently work in Pinal County, and since we are talking about Arizona, I guess we can bring all of this to the fore. Currently, we are short on mental health beds all across the state. In Tucson or in Pima County, we're a little bit better served with the fact that we have more facilities that can do involuntary treatment for patients who may need to go on one of those involuntary stays. But for the most part, we still have a limited number of beds, though we're doing better in expanding. I think most health units in our state or in our city have expanded their numbers, but we're still short. We're noticing less so that we have to send adults up to Phoenix, but for children, there still seems to be a kind of need to send them out of town, because we also notice that we serve all of Southern Arizona. So we're not just serving Pima County, we're serving all the surrounding counties as well. And then we're noticing that up in Maricopa County, the total number of involuntary beds is very limited. So the number of voluntary beds is maybe better than it is in our county. And then in Northern Arizona, they're essentially struggling with both. So we have challenges that are very unique in each of the counties, but at the end of the day, the most important thing is to continue to work in the direction of increasing the number of beds, improving access more in rural places, so which is where we're going to be looking to see if that bill that was passed for primary care physician increases will also impact mental health or not. So those are some of the things that we'll continue to work on. And then also to just try to get more doctors in our state overall.
And you mentioned marijuana and the legalization issues, and I'm curious if there's lessons learned from other states, Colorado and the like, that we're preparing for in Arizona as a result of that, or things that you've seen, whether it's with adults or youth, that we may see coming our way.
Yeah, some of the data from Colorado, California, et cetera, hasn't quite fully been shared yet, but some of the initial information that we have does show that there is increasing numbers of mental health concerns that show up, especially for individuals who may have psychotic disorders. We noticed that going up, but we also are starting to see in some of those states more anxiety conditions. And for us as doctors, we're not really educated in how marijuana will interact with all the other things that we're using for treatment. So that is something that we're waiting to see what some of the studies in those states show as well. But I am bracing myself, like I said earlier.
Well, I've heard, that the potency, for example, is much higher in a lot of the marijuana now being cultivated. And again, I'm no expert, but just hearing about issues of that in youth getting a hold of it and other things, and the implications of it being much more severe than what we used to think of it as anyway.
Yeah, I think there was a study in a conference that I attended a couple of years back where it showed that now the potency is sometimes 2 or 3 times higher and sometimes even more. And then they did a study where they gave people a marijuana strain that was, say, a potency of 1, and the other one that was a potency of 1.6. But it didn't show that if when somebody was smoking that they actually reduced their usage per the potency. They maybe reduced it a little bit, but they continued to smoke more or less like almost 90% of what they smoked before. And so we do know that as people start having access legally to more just high potency marijuana, that people will use more and may make it that it's more okay to use. But on the other hand, I think people who've tried to pass it, their argument is that in some ways it may reduce the illegal drug trade. So we'll wait and see how this little experiment pans out. It's concerning, but here we are.
And I know we're just a couple minutes over, but since we do serve an older population, I was kind of interested in understanding sort of the implications in our state around older populations and mental health, and if you're seeing any interesting trends in that area.
In that area, we have noticed that the total number of geriatric psychiatrists is not essentially increasing at the same pace as we would want per our population. However, there are more resources that are coming available through healthy living programs or healthy aging programs. So those are some of the promising things. However, I think my thought for anybody who's on the call today is that prevention is better than cure. So if, currently you're in a place where you are able to take steps to improve your mental health and really commit to it like you commit to your daily walk or your exercise or your yoga or Pilates, whatever you're doing, to continue to take some time to check in with yourself to see how you're doing, and then alert your primary care physician if at all you need help. But in the interim, to try things like cognitive exercises, meditation. And I think in that sense, the next talk that will be happening around mindfulness meditation may be very well suited so that people can continue to support their own well-being as they're going through later stages of life.
Dr. Chatwal, I really appreciate your time, and you're obviously a shining star in this state, and we appreciate your expertise and all you bring to this topic. And want to thank everybody for joining us today. And again, reminder that we have one more session coming up on April 7th in our mental health series. And as always, our program is here to serve and keep you active mentally and engaged socially in all sorts of ways like that. And thanks to all of our attendees with their incredible comments. We'll make sure that Dr. Chatwal gets all those as well. And you have any other parting words for us today?
Thank you all. Thanks for attending. And I hope you'll continue to stay engaged in the things that motivate you and that give you joy.
Thank you so much. And we will have this recording available as well off of our website in a couple days. And again, so if anybody needs this as a resource, we'll have that for you as well. But thank you so much once again, and thanks to the University of Arizona College of Medicine Psychiatry for helping support this. And we hope everybody stays safe and well, and we'll see you in our next session. Thank you so much. Take care.